We're absolutely delighted to welcome Peter to King's. As I'm sure many of you will know, he's recently moved to us from the University of California, San Francisco, where he ran a world-renowned headache research program and headache clinic. Peter's career began in his home country of Australia, and he obtained his basic medical degree and his training at the University of New South Wales. And his neurology training was under the supervision of Professor James Lance. And I know Professor Lance is held in great affection and esteem by Peter's colleagues and generation of neurology trainees. I'm hoping, if I can advance the slide, which I already promised. So this is a picture of Professor Lance in the centre in the grey suit. And this is around the time Peter was just completing his MD studies. If you look very hard, you can spot a handsome young fellow on the steps, which is Peter Goadsby at the very embryonic stage of his career. After postdoctoral work in New York and Paris, and postgraduate neurology training at Queen Square, just up the road in London, Peter returned to the University of New South Wales and the Prince of Wales Hospital in Sydney as a consultant neurologist and was appointed associate professor in 1995. Not long after that, he was awarded a highly prestigious Wellcome Trust Senior Research Fellowship, which he held at the Institute of Neurology at UCL, just a few minutes away from us in London. He moved to San Francisco in 2007, and we were delighted to welcome Peter to King's in August of last year. As I'm sure many of you will know, Peter's a neurologist interested in headache. And I would say, and I think Peter would probably agree, that a serious academic interest in headache disorders is a relatively unusual thing. And I was interested to learn how Peter came to his interest in headache just through Googling you and just having a look around over a few minutes at weekend, Peter. And I found an interview that you'd given in the USA, and you said something very straightforward, which was that the prompt to get into headaches was a lecture that my mentor gave many years ago about migraines, and I guess this was probably genital Lance on the screen there. And what you said was, I found the explanation unsatisfactory, and it was the first thing in the medical school curriculum I found interesting, and I've been interested in it ever since. And that's a very straightforward way to arrive at a specialist career. And as we'll hear, Peter's interest has expanded vastly in headache disorders, and his work involves human imaging, electrophysiological studies in primary headache disorders, and experimental studies of the trigeminal vascular pain system. And his work aims to understand which parts of the brain drive and modulate headache syndromes, and how those might be modified by treatment. So it's with very great pleasure I introduce Peter Goadsby to you, and we look forward to hearing his inaugural lecture.
Thank you. You'd be relieved to know I'm not going to wear the hat the whole time. Thank you for the introduction. It's a pleasure to be here to talk. It's a nice picture. A little bit frightening, really, to think I was once that young. I want to start out by, I'm going to talk, of course, about headache, and make sure my slides will come up. Yeah, got the right place. I'm just going to talk about headache and talk about how to improve care by taking ideas from the bench and driving them, literally driving them into clinic. I'd first like to thank everyone who was involved in my moving here. I've seen a few people out. Nahi Khan pointed out to me at an American Academy of Neurology meeting that this job was available, and we were sitting listening to a talk by one of my US colleagues who was droning on a little bit, and that's what struck my interest. I've got to thank Chris Shaw for being so helpful in the arrangements around moving the laboratory. I have to thank Mark Richardson for putting up with a number of tedious calls. He gave me his mobile number rather than nasally, and we listen to sort of pathetic things that people talk about when they think about moving, like, please, you wouldn't make me retire, would you? It's one of my great paranoias that I'd come to a place that would make me retire. I've got nothing else to do, so I was worried about that. Shetish Kapoor was remarkably frank, incisive. I mean, he's typical of the very collegiate attitude that there is here, which I find surprising, really, that there are so many great people here. Tim Smart, when I met him, was incredibly agreeable as having practiced 12 years in the NHS, you get an impression about the NHS a little bit, and Tim Smart just does it different, and I tell people that. And Sir Robbie Radcliffe, who I met him in his squash court in office at Guy's, and he asked me the one question that really made me think about whether I wanted to do it. It was the right question, but just the one question about it. You know, have you got to a point in your life where you want to stop, where you want to do something bigger than just doing your own thing? He described it as ploughing your own furrow, and that phrase stuck with me. It enabled me to make the decision because it really crystallised it. So thank you to everyone who's been so agreeable. Thank you to everyone in the CRF who works so hard. I wanted to say this now because it's important. To Elka, who manages it so well, to Peter, Bishop, who looks after the facilities, and to Penny Hammond, who is totally reliable in obsessively keeping a track on our financial records. And last but certainly not least, Alison Worth, who actually made the transition possible. I would have gone crazy and had no hair if I hadn't had her assistance, and I thank everyone for doing that. Mark's quite correct. When people think about headache, they kind of think of it like, they look at it like this. And you could look at that and you could see two things. You could see dirt, that's one possibility, and that's unfortunately the way neurologists largely think about headache, common and not very interesting, dirt. Or you could look at that and you'd say, wow, that's Mars. It's a picture from the Mars lander. And that's really interesting, and if you understood it, God, we can understand things about the universe and so on. So, I mean, I look at headache not as common dirt, but I look at it as a Mars opportunity. And I want to show you how I can take a few things and spin them around the world, so to speak, for a Mars opportunity. These are the disorders that interest me, the headache disorders, and I'm really interested in the primary headache disorders, not so much the secondary headache disorders. It doesn't strike me as all that very interesting if someone has an infection or a brain tumour, with all due respect to Ash and his colleagues, that you would get headache, because that seems a bit obvious. But great that you look after it, and please continue to do that. I'm quite interested in the primary headache disorders. These dreadful disabling problems, and I see patients, and I'm grateful to the cluster head ouch people and Migraine Trust who come along, have worked well. I'm grateful for their involvement. And these are dreadful, dreadful conditions. I'm going to focus, I won't deal with the other primary headaches, as you can see how creative the classification committee became. When we got to number 4, we just called everything other and went from there, which is a little bit, well, we'll work on it, let's put it that way. Some of them are particularly interesting forms of headache. Things like nummular headache, which is someone who complains of just the size of a coin, pain, but I won't go into that. Stabbing headache is what happens when it feels like a stabbing, and exertional headache is when you exert yourself, and except if you exert yourself, they're under section 4.3, whether you're exerting yourself or someone else is exerting you or whatever's going on. It is a very special category, one that I'd be happy to cover in question time. There's an interesting thing, I did political correctness training in the University of California. What's it called? Harassment training, that's right. Because you go to the training and you sort of smile and say, oh, you're going to teach me how to harass people. And this lawyer lady looks at you like death warmed up. But anyway, I learned something really interesting. American academics have First Amendment protection, freedom of speech protection, to talk about sexual matters in any purity and detail they wish, as long as it's in an academic teaching context. And this has been tested by the Supreme Court. And often in the US, when I was talking, I would say that I could talk about it in purity and detail or First Amendment protection, and the occasional person thought I was serious and was going to show pornography or something like that. And in the Midwest, that didn't go down terribly well. The principal would be relieved to know that I've left the subject behind this evening. We talk about two things. We talk about cluster headache and some ways that we've taken bench work and it's coming to fruition in clinical trial work. And then I'm going to talk about migraine. It's usually the other way around. But I want to do that differently because it's an important subject to me. We'll get some impression of why it is in a little while. Cluster headache is considered to be one of the section 3, one of the trigeminal autonomic cephalalgias. That's a term actually I dreamt up with Richard Lipton. Actually, I dreamt it up in the shower one day. I was trying to think about how you could gather these together. And if you want to get a term people like, it's got to have an acronym. It doesn't matter if it's accurate or not much matters in medicine, but if you can make an acronym out of it, people just love it. And they'll jump on the acronym. So that's why the term's been picked up. And when we talk about cluster headache, I won't talk about the other forms of the TACs. This is a picture of a person expressing what it's like to have cluster headache. Many neurologists think that's a picture of them in a clinic seeing patients with headache. And I often remind them that actually the person pulling their hair out is the one on the other side of the table, and it's a useful thing to remember. There's much history in cluster headache. Mark said he was going to show a young picture of me, so I thought I'd show, because I'm a modern chap, a selfie of myself and Jim Lance about 3 months ago, or 2 months ago. He's going well, he's 87. We had lunch, we ran into a patient of his who looked 87 as well, but who he looked after, and his only concern was sort of, he said to me, oh, I wonder if I helped them or not. Ever to the grave would be concerned about that. This is what cluster headache used to be. It had very sort of strange views about this, strange names. In the UK it's been called migrainous neuralgia. Wilfred Harris, this rather austere chap, was a neurologist in London, and he called it migrainous neuralgia. The problem with this is it's not migrainous and it's not neuralgic, which is quite unhelpful, really, is the term. Apparently he was at his best during the Blitz, when he was a person who was driving people down into the tunnels and having a splendid old time disciplining the troops, so to speak. Histaminic cephalgia is an interesting one because it's not to do with histamine. Petrosal neuralgia, well, it doesn't work either. Sphenopalatine neuralgia leaves out a lot of things, and these are all very peripheral names. These hemicrania periodic neuralgia formis comes to the German one. This is a German name as well, Bings. Horton's headache is something the Swedes very often say. This is Baynard Horton, who described the syndrome quite well, except he left out the clustering part, which is a bit unfortunate, but there we are. And ever the understated Englishman, Sir Charles Simons, just called it a particular variety of headache. Ever the English understatement. And there's Charles Simons, bird watching, with someone who I learned much of and looked after actually as it was when he had headache at Queen Square in a younger era, famous MS-ologist Ian MacDonald. So these are people. And the other thing about cluster, Jim Lance has cluster headache. He hasn't had a bout for about 7 years. He used to get them every 3 years. I didn't know when I first started doing research, but one day he turned up and he was using his oxygen in his office, and it worked quite well for him. So I've always had a soft spot for both Jim, after whom I named my first son, and the condition. Cluster headache, for those of you who don't think about this all the time, is a short-lasting headache, so they last a couple of hours, in contrast to migraine, which lasts for many hours. They are very much lateralised on one side of the head. They're associated with watering of the eye or redness of the eye, nasal blocking, some ear filling, the eye drooping. And it's very much associated with a sense of restlessness or agitation. You can pretty much divide migraine and cluster by thinking about this in terms of the fact that about 90 to 95% of migraine sufferers will prefer not to move about or sit in the corner and leave it alone, and if they shake their head about it, gets worse. And cluster headache, 90% plus will want to get up and move about, and they'll shake about, and there are videos of people out chopping wood and doing all sorts of things. The contrast between migraine and cluster headache just in behaviour is a really high value question which far exceeds the value of doing scans on these people. The history is wonderful. I'm going to return to that because actually we start to understand where that's coming from, which is extraordinary. These patients have many of these attacks a day. They will tell you to a man they haven't had worse pain, and they'll tell you to a woman that they haven't had worse pain, and that includes childbirth. You have to consider, boys in the room, what it would be like to give birth to a child 2 or 3 times a day, every day, for months. Just consider that for a moment. That's cluster headache. That's horrible. And that's why it's important to understand. As I say, it's more of a male than a female problem, 3 to 1 males, in contrast to these other syndromes, which tend to be about equal. The attack frequency goes up as the attacks get shorter. The eye watering is very prominent. They get some migrainous features. They typically treat with alcohol, whereas the other syndromes don't. And there are some good treatments. For example, oxygen is extremely effective, and I'll come back to that, which is not particularly effective in these other syndromes. These syndromes are marked by this cranial autonomic activation, and that's how, I'm going to tell you a little bit of I'll tell you a story if you want to start with where I got interested in it and how it's evolved along, and how that's led to something translation. So a long, long time ago, in a galaxy far away, when I was a lot younger, even younger than I appeared on the desk on those stairs there, we were interested in brain areas that might be involved in migraines. It was. And what I observed in an anaesthetised cat was if you stimulated the structure in the brain, the locus coeruleus, which has about 95% of brain noradrenaline, very interesting structure, we'll come back to it a little bit later. One of the things that happened is that the cats would lacrimate, they would tear, they were anaesthetised, they weren't crying, but it was one-sided lacrimation. Their eyes would go red, they would salivate. And that struck me as interesting. And I started to explore it a little bit. And what I was able to show was by cutting the spinal cord, and that took a little while to learn. We cut the spinal cord, and the animals didn't die in a sort of classical Sherentonian fashion, that it was preserved. And I was able to show that if you cut the facial nerve, as it exited the brainstem, that response would go away. And effectively, that last picture, which is a nothing picture but an everything picture, is what kept me in research. There was a night, I think I'd done 3 or 4 of these, and for the people thinking about getting into research, it's the sort of feeling that you have. I looked at these and I thought to myself, I know something other people don't know. And I didn't know that for sure, but I was young, and I thought, wow, you do research and you know things, and then you can tell other people, but for a couple of days I'll just keep it to myself, and I'll be the only person who knows this. I found it really exciting. I know I have to get out more and do other things, but I found that incredibly exciting to know something. So there was a cranial autonomic activation. It was lateralised and it could be blocked. But what also helped me at this stage is I presented this work to the Department of Physiology and Anatomy at the University of New South Wales. And one chap said to me, "This is nonsense because that's not been described before." And I thought, okay, it's an interesting way. That's like, right, that was like a red rag to a bull. So I'm saying, oh, okay. Fortunately, Jim Lance smiled and said, oh, well, that's what good research is about. If people describe it, why bother doing it? So we did a number of studies, and we're able to show that you could extirpate the pterygopalatine, the sphenopalatine ganglion, and there's a prominent effect also on the aortic ganglion in cat. But the sphenopalatine is an important thing to talk about, and here are the quantitation of the data. And you could block this outflow, so it came out the greater superficial, the 5th nerve, and into the pterygopalatine ganglion. And you could do that all anatomically, and you could show that cranial autonomic activation. And of course, cats don't have cluster headache, experimental animals don't do that. What they enable you to do is dissect mechanisms, and you can make predictions, and then that's what translational research is to me, to make a prediction, get into humans and try and take advantage of it. And the prediction would be that if you interfered with these with the sphenopalatine ganglion, that will be a target, certainly for cluster headache. Now, at the same time, I made some observations. So I'll come back to this because it's an important part of the second story. I took that information at one point to humans. So I wanted to understand one of the things that marks this dilatation. We did some experiments in animals with Graham McDonald and I to show that this was due to a VIP mechanism. And with all this with all this information, this new system, we sent it to the journal Nature. It promptly sent it back and said, this will never amount to anything interesting, or the way they send things like that back. And I encourage all of you who ever get letters like that not to worry, because when people send you a letter saying, I don't understand it and this will amount to nothing, it's either really interesting or it is nonsense. So don't worry about it either way. The truth always comes out. Anyway, they sent it back and we published it in another journal. So I wanted to look at the question in humans, and here we're showing in humans. So we take a patient with an acute cluster headache. When I was young, I was living close to the hospital. I was living in hospital accommodation actually. And I struck up a relationship with Lars Edvinsson, a Swede, and I'll come back to that relationship in a little while. And we were able to show that you could have a marker of trigeminal activations of the pain pathway, calcitonin G-related peptide, elevated in these patients, and a marker actually, VIP, came out. Now VIP, vasoactive intestinal polypeptide, is what that parasympathetic nerve system uses. And here what we had in humans was a marker that what we were doing in the cat was very close to the manifestations that were happening in humans. And that's a sort of a first sort of vault into the translational world. And this has proved to be quite a robust observation. And this is trigeminal autonomic activation, and that's how the thing comes about. And so now, through a lot more work, we understand this system quite well. We understand that pain signals come in through the trigeminal nerve, the first division mainly. So the first division is the one on the top of the forehead, the second division is over your cheek, the third division is down in the jaw. And somehow, the way God designed it, and I mean that to use it in a generic sense, I'm not trying to implicate any particular religious belief. I spent too much time in those courses, didn't I? God might have designed it. The first division, people when they hold this, they say headache. And when they hold this part of their head, they call it face. Always strikes me as interesting, but it seems like our lexicon for headache is a first division experiment largely. At any rate, the pain comes in here. We've shown experimental animals up to and including non-human primates that it descends down to the second division of the trigeminal of the cervical, for which accounts a lot for neck discomfort, and I'll return to that. And then the reflex, we've dissected that out. The old lamp at night did most of this work. This is FOSS work, and we know what the transmitter is in here. We know this comes out the facial nerve that we did the sectional work on. We know it doesn't synapse in here and goes straight out to the sphenopalatine. We know nitric oxide is involved and VIP gets released out here. We know all of that, which is quite a lot to know about this reflex. And these are the clinical manifestations. So this allows you to predict a number of things about this system if you interact with it, or perhaps block what's going on out in the periphery in terms of the clinic. So, what's that resulted in? Well, people have been doing lidocaine blocks in the sphenopalatine for some time. The thing which is really going to change a lot of refractory primary headache are going to be neurostimulation techniques. And I'm pleased to say that that work that started in 1983 is really the translational intellectual basis for this study, which is of a sphenopalatine stimulator designed by a Californian company. You see the person's finger here. This is a very small device that's poked in the top up here through a little cut. It seems easy, but the facial-maxillary people really know what they're doing. A few little screws to tighten it on the jawline there, and then it doesn't have a battery. The current's induced here. Hold it on the outside, turn it on, and you'll see what happens at 15 minutes. You get a very decent, non-shabby response, it has to be said, and many of these patients have reductions in frequency. And this is now bubbling along in phase 2 trials. Real serious translation for a group of people who have just dreadful problems. So the work done in the cat is actually producing something useful. Now, another thing that I learned when I was at Prince Henry was that if you inject the occipital nerve, it's a little bit harder in most people. You've got to find it. This chap's removed his skin for anatomical clarity, which he doesn't usually do. But it's not too hard. You put your finger on the mastoid process and the index finger on the occipital protuberance. If you imagine there's a line there, just drop your finger under the base of the skull and you push it a little bit, and people with cluster headache will jump off the bed. What you would predict from that trigeminal cervical information I showed you is that blocking this would be helpful, and indeed it's helpful in cluster headache. And what these systems predict is that there might be a generic effect of altering the way occipital input comes into the trigeminal system. Now that's a question you can get at experimentally, and it's a question you can get at in humans, and you can translate it. So let's talk a bit about how you might have done that. So how did we get off this? The first place we got to was to take, we were using cats quite a lot back then, stimulate the sagittal sinus, a large vein in the skull, and it's pain producing in humans. That work was done by Penfield and various people, perhaps in the 1950s. And you can show using metabolic methods, this was 2-deoxyglucose, that there's activation out here at the C2 level. It began to get us interested in that. Fast forward, what we're talking about is a pain activation that comes from the cervical input. And what we've shown is that it goes into the cervical input, but it also goes up to C1 and up to the nucleus caudalis, so trigeminal. And the trigeminal input goes all the way down. You can Torsten Bartram, who was with us, this is electrophysiological work, and what he's doing is you record from a neuron down in the spinal, the nucleus caudalis, the trigeminocervical complex most caudally, and you can, you record the neuron and it's firing off, and you stimulate the occipital nerve, and then the firing from the trigeminal nerve is increased, it's sensitized. What you're showing is what person tells you fundamentally in clinic very often when you see them. Many patients will say, I've got pain, it's a band around my head like this, or it's coming from the back to the front. Now there's no nerve that goes from the back to the front. There is a branch of C1 which will go just to the eye, but there's no nerve that goes over like that. And there's certainly nothing that wraps around the head. What I find wonderful about this anatomy and physiology, every time I see a patient who tells me they've got a band or some squashy thing around their head, they're telling me at least that they've got trigeminocervical activation and that they feel a bit tender, they're telling me they've got sensitization. You know, if you look at patients like that when they're telling you something like that and you can understand it, it completely transforms the way you think about the clinical interaction. It's no longer some sort of dialogue of disinterest. It becomes a dialogue of understanding, and you explain that to someone, and they can get some comfort with the idea that this pain will happen all around the head, and it will happen in the neck, and they don't need to see a chiropractor and be twisted around and pithed or something crazy like that, because all they have when they have neck discomfort is activation of this system. Now, the other thing that we predict from that is if you try to perturbate that system, let's translate that. And what we kicked off several years ago now was to stimulate the occipital nerve in patients with cluster headache. These are two reports that show in medically intractable cluster headache. So these are people who've had everything literally and still have this dreadful chronic cluster headache problem. At the time, the other thing that was being considered was deep brain stimulation. I'll come back to why we didn't do that. And we've got quite reasonable outcomes. Some of the patients who were dreadfully disabled did extraordinarily well with this. I think that this is an interesting thing. It proves that it certainly establishes that there's a role for this interaction, which, as I say, is effectively born from cat and then rat experiments showing the trigeminocervical system, predicting that this would happen, and then one can take it again into clinic. Now, what would be great is to start to understand how this happens, and this is where the how is one of the things on the clinical side that functional imaging has helped us a lot with, and it's something I really think that we can make some great grounds with as I really look forward to work with the functional imaging folks here, Steve Williams and Fernando Zelaya, Gareth Parker, a friendly bunch of guys with a lot of knowledge. Now, oxygen. Oxygen is useful for cluster headache. People say that. Prior to this study, there were 14 patients in the literature in an incomplete crossover study. That was the entire world literature on the subject. So we went about doing this. So this is going bedside to bench. I'm going to show you what we did to establish if it's true. And then I'm going to show you, because you're going to ask the question, well, if this works, how does that happen? Because that's a good question, and I've got some answers to that. So we did this. I'm very proud of this study. 76 patients. Double-blind, placebo-controlled, entirely academically driven, The gas people gave us the bottles, but they gave me a hell of a lot of grief because it took us quite a long time to get this done. They would have done like in 6 months, and it took much longer. It took us a lot of time to get started because the ethics committee turned it down because they said the patients had blown themselves up, because cluster patients who smoke quite a lot. But in the end, they accepted when the cluster patients told them to get lost, that they wouldn't blow themselves up. And in fact, there's only one person in the world with cluster who's ever blown anything up. A Texan chap who picked up a half dozen bottles of oxygen in the middle of summer in Texas, parked his truck at a diner, went in to have lunch, and then left his truck in 35 degrees Celsius with the windows wound up with oxygen bottles, and it blew up. But I think if you're going to do that, that's a whole other type of person. At any rate, 76 patients, 278 attacks. This is an air and oxygen. That's very difficult to tell that apart. This is a very nicely blinded study. That's why I'm quite proud of it. Because this is now the study everyone quotes when they say, oh, we need to use oxygen in cluster headache. And the Department of Health uses it, and people all over the world use this. And it brings me to the point of saying that partnerships with patient groups are crucial to doing this sort of thing. We've never got this done without the relationship that we've built up over the years with the Organisation for Understanding Cluster Headache. You just can't get this sort of thing done if you can't work with patients. But if you do, you have then the defining study, and our colleagues all over the world refer to this. And you're looking at this difference, and you're saying, so that's spectacular. Okay, not everyone's saying that, but some people are saying that's spectacular. And some people who are still awake up the back there are saying, how would that work? How would oxygen turn these neurons off? So, Philip Holland and Simon Ackerman have been working on a model of this in experiment. Phil's just joined King's, a lecturer position in neuroscience. So if you record from trigeminal neurons, you can find neurons that you can record from trigeminal neurons. You can record from a durovascular effect that's not affected by oxygen at all. The reason I say that is that triptans, like sumatriptan, is very good at migraine, would show a decrement here. So there's a differentiation, is the point that I want to make. Now the uniqueness of this model is what they did was use a laser Doppler flow meter to do lacrimal gland blood flow, and use that blood flow in the lacrimal gland as a surrogate for tearing, the cranial autonomic symptom. And you see that that's very nicely linked to stimulation of the superior salivary nucleus, as you predict, and that you can inhibit that with oxygen, just like you can do in humans. And I'm not saying that rats have cluster headache. What I'm saying is, here is a model that behaves in the same way as patients in a randomised placebo-controlled trial. But I can go and explore the pharmacology of that. I can understand how that works better, and I can understand what the next generation of things will do, and make predictions out of this sort of work. And that is bedside to bench translation. It's eventually going to come back to produce something useful, because this is the other model I'm attaining. Now, functional imaging has been very good to cluster headache, and this is a summary of things that we were doing. The first of the studies, and going back to 1998, people thought that cluster headache was some episodic inflammation of the base of the skull, blood vessels in the base of the skull, which sounded to me crazy, I have to say. I always thought it was crazy. Not every idea I think is crazy, I have to say. I'm only showing you the ones where I got it right, because it's an inaugural lecture, so I don't see any reason to show you too many errors. But you can find them if you Google or PubMed. So I had the idea that this must be a brain problem. Here's a problem that these people have these attacks, they're clock-like. And the other beautiful thing about cluster headache, like from an interest point of view, I must say nothing's beautiful about cluster headache from an experience point of view as far as I can see, is the circannual periodicity. So they will have their attacks at the same period of time, the clock change time, every year. I mean, that's just wicked. Or once every second year, that's even more wicked. It's just amazing the way these things, and then they'll have an attack at the same time at night. There are even, and I've seen one twin pair who have their attacks at the same time of the day, when they're not living in the same city, and not talking to each other at a particular time. There's something incredible about the biology of this. And, you can look at this from the clinical point of view about understanding that, or you can look at the wonderful opportunity to understand human biology
when it's altered by a disease process. And that's one of the unique things that clinical scientists can do. You have to have that interface to be able to take these advantages. At any rate, we've got patients in the scanner, and this is again an interaction. How else am I going to do these experiments if patients are not going to come along and let me trigger a horrible headache to lie in the scanner and let us scan them? It's fantastic they'll volunteer to do it. It's almost amazing, you have to say. But they do it. And what we showed was activation in the very back part of the hypothalamus. In fact, it's not clear whether it's in the hypothalamus or just behind it, and it's actually not clear in humans what defines the back of the hypothalamus. And Michaeli Vassilandra, who's worked with us for many years and continues to collaborate with us on the human anatomy, is interested in this because it's remarkable that this area is not anatomically defined. And it's human, but it's humans. It's not like donkeys or something like that. It's remarkable that it's not defined. And we're working on a brain, as an aside, it's an odd thing happening because one needs human brains. And where I got the first one for cluster headache was a guy called John. It's quite interesting. His wife rang me up one day. She said, John's died. I thought, oh God, what have I done? First reaction. Oh no, John was fine. He had some other problem. He's very happy with you. He's always happy with the way you looked after him. He wanted to let you know that, blah, blah, blah. So it's very nice of the guy, bereavement. And the other thing is he wanted you to come to have his brain. So could you possibly come and pick it up? It's available. Well, you can't just get in a taxi. I can tell you, you can't get in a taxi with a pot of stuff and go and pick up someone's brain from somewhere. It's not going to work. But eventually, because John wanted us to have his brain, we had John's brain, we have his order of service, and one day we're going to have this sorted out because John wanted to give his brain to us. And it's emblematic, again, of the interaction that you could have with patients. It's quite a remarkable thing, really, when the last thing someone wants to do is make sure that they get that you get their brain. Extraordinary. And I'm grateful to that, and I'm grateful for all those interactions. Now, one of the interesting things, no, it's not interesting, I should stop using the word, is what happened after this. We showed the imaging. Our Italian colleagues had a dreadful patient with cluster headache who had, it's a dreadful problem. What the surgeons used to do is, for very bad cluster headache, they do trigeminal nerve sections. So they get in there, with all due respect to Tony Strong's surgeons, and they chop the nerve. And that's a pretty serious business, chopping someone's trigeminal nerve. And from time to time it goes wrong, because even in the best hands in the world, posterior fossa, nothing fiddling around, and stuff doesn't go well. This poor guy, they cut his nerve, and he was anaesthetic on that side, that was fine. And his attacks the next day swapped to the other side. Okay, yeah, someone's got the message. That's like, okay, great. And then what happened was he tripped over and injured his eye, and he got an infection and lost the eye that was where the trigeminal nerve is section. So here's the bloke who's got cluster headache, who's now got only one eye, whose attacks have swapped over to the other side. So, do you want to chop the other nerve and make him blind? No, I think the answer is no. Not even the craziest surgeon would do that. What they did was they saw our paper in Lancet, and the Italians, God bless their soul, I don't think I'd have done this, they put an electrode in there and stimulated, and lo and behold, control this cluster headache. I think this is the first example of disease, serious functional imaging study in disease that gets, boom, translated to something that actually gets used by people, and it makes a real big difference. This bloke didn't lose his eye, his attacks settled down, and he's done very well. That doesn't work for everybody, and unfortunately, soon after this, Jean Chernin put an electrode in someone's head, and they bled and they died. And it doesn't matter how good everyone is, occasionally if you drill holes in the skull, God meant it to be in one piece, bad things happen, it is what it is. Not very often, I understand, almost never at King's, I get that in time. But, nevertheless, non-invasive is better. I get that. I've got to have friends after, so I've got to be So that's why I'm interested in the non-invasive techniques, because I'm a physician, I'm more or less spineless. I think if someone's sort of vaguely unhappy, that's a disaster, and I think if they die, it's like, well, that's just beyond the pale. So I like non-invasive. And the other thing that's come from this is more physiological, and it is fascinating when you think about it. I showed this picture to a functional neurosurgeon at Queen Square one day, and we were talking about this, and he jumped up and jumped out of his seat and said, oh, I've seen that area before. And he ran to a book, and he got a book off, then he opened it up, and he pointed out this area of sana, and said, oh, a Swedish neurosurgeon, who chaps will know well. I've been doing psychosurgery on crazy people in Sweden to find us people who run around chopping themselves. And I don't know anything about psychosurgery, I don't have a view on that. But what they noticed, that when they stimulated this area of Sano in people having psychosurgery, that the patients, not cluster headache, these people are crazy, had restlessness, agitation, and they wanted to move about. Now, what did I say cluster headache patients do 92%? They have restlessness, agitation, and they want to move about. Now, in neurosurgery, I'm told, it seems logical, that being restless and agitated and moving about is very unhelpful as they're drilling and doing things like that. So the surgeons quickly learn to anaesthetise people and so to get around that sort of thing. But nevertheless, the idea that we could come from cluster headache, where people are restless, agitated, want to move about, and identify an area that's important, and then you could come from a totally different place, and you could put an electrode in there and stimulate it, and they would be restless, agitated, and want to move about, and you could poke the electrode in there and you can improve patients. This area must be important. And that's why we're focused on it in a laboratory sense. I think Holland's interested in it, the orexinergic connections, because we've gone bench, the idea, to bedside, with the imaging, and then eventually the surgery. We're going to go back to the bench to work out what this area is, because understanding this area has got to be important in understanding cluster headache. Let's get the next one. So, I spent the first half on cluster headache. Yep, timing's not too bad. I want to now say some things about migraine. I'll talk about migraine monkeys in there. You know, again, it comes a lot to this question of how much you can use translational research. I mean, monkeys don't very often complain of headache in our experimental animals. It's a tricky question, but I think I've shown you a little bit. It's possible to make some very good predictions and do some very useful. So migraine is an episodic disorder. Typically lasts between 4 and 72 hours. It's unilateral, pulsating, moderate or severe. It's aggravated by movement, nausea, vomiting, photophobia, and phonophobia. And even in a kind of half-baked Norwegian, which is what this is, because this definition's been around since 1988, and even an enthusiast has to do something. So I've got about 25 different languages. I collect them, when I go places. I think, the headache business is so straightforward, you can understand practically the diagnosis in Norwegian. I mean, why do people complain about the diagnostic system? Rich tapestry of problems. The start of the attack, the premonitory symptomatology, showing some specific things about that. The pain, sensory sensitivity, light and sound sensitivity. Repeated attacks. A family history, very, very important. And the much vaunted triggers, which we've been coming to understand in different sorts of ways. Nitroglycerin triggering, very helpful in the translation laboratory sense, because you can turn on about 2/3 to 3/4 of patients by giving them nitroglycerin and triggering attacks, which of course captures them to enable this really great, some great work. I'm going to tell you one story about migraine and where the bench has gone to bedside, and the bedside announcement just made last week. So this is just the latest bench to bedside story. And unfortunately, this is Noel's story as well. So in June of 1985, I was visiting Sweden for a meeting, and the meeting was held in this building. It was neural regulation of the brain circulation. The reason I remember, I'd not been to Europe before this, and it was midsummer, and I just thought it was like just completely whoa. It's 4 o'clock in the morning and the lights are on. I mean, the sun is up. Amazing. This guy, Edmondson, who I struck up a very long term, you're not drinking, it's just a pen, showed this piece of data. And it struck me to think, and the difference between this effect is the ability of the trigeminal system to protect the cerebral circulation is mediated by CGRP, calcitonin gene-related peptide. And we got together and we asked ourselves the question, is CGRP going to be a marker we could use to look at bench questions and see if we could translate them into bedside? That was the beginning idea. And actually that's a picture of the place we had the meeting in. That's where we had the idea. That's that. So, first experiment we did was to take cats first and then humans, and showed if you stimulate the trigeminal ganglion in either, that you would get release of calcitonin gene-related peptide and substance B. Substance B was flavoured of the month back then because it's in pain neurons. The pain people thought it was going to be the big deal. The Harvard people said this is the answer to everything. And you know, if the Harvard people say that's the answer, everyone goes, yes sir, no sir, that's exactly right sir. And so, you know, we were reasonably happy that we found that. We then asked the more important question, you know, migraine is not about every sensation. You know, if you go home and you're late, buy something, a present or something like that. If you get in trouble and you get hit on the face, something like that, you feel pain. That's a trigeminal ganglion mediated thing. If someone strokes you on the head, it's a trigeminal ganglion mediated thing. It's very non-specific. So what we wanted was a more specific translational stimulus. And where we went to was sagittal sinus stimulation, which produces pain in humans. So we've used dural stimulation, cat and subsequently in rat, to stimulate pathways that are clearly going to be relevant from an understanding the pain pathway perspective. And when we did that in the cat, what we found was the CGRP was there, sure. VIP was there because we drove the cranial autonomic outflow, but there was no substance P. And of course people said, that's rubbish, you must have had a duff assay, blah, blah, blah. That can't be right, because substance P is important because Harvard people say it's important. Life's a tricky thing. So we then drove the hypothesis, well, if CGRP is released when you stimulate the dura is supposed to be pain producing, what would happen if you went and looked at this in migraine nerves? Am I wasting my time studying these systems, or do they have relevance in migraine nerves? And here's the translational piece. We went and looked at migraine with aura, migraine without aura patients having a really bad migraine in the pre-triptan era, and you see CGRP's elevated, and I was amused to find that substance P was not elevated. And I thought this was really cool, and it really said like substance P ought to not be important in migraine, and CGRP ought to be important, and you see we had another control of neuropeptide-wise, it wasn't just a volume thing and so forth, so I sent it off very excited to the New England Journal of Medicine, who sent the back letter saying, this will never amount, this is an epiphenomenon that will never amount to anything useful in medical practice. I still have the letter, which you'll see in a few minutes why I think that letter probably overstated their position. Anyway, they thought it was nonsense and sent it back to us. Life's like that. So then we went along and we looked at sagittal sinus stimulation again. We compared it. We used a triptan to see what would happen. This is amitriptan. The reason we did it was because amitriptan was a good triptan. It worked very well. Never got into clinical practice. It had a nickname called hepatonecrotriptan, which it developed on a patient blog or something. So you can understand that sort of nickname didn't help, and they stopped the development. But it was a pretty good drug to use because you could get lots of it. The company didn't want it. What in contrast, the other thing with contrast here is neurogenic inflammation drugs. Another competing idea that was that neurogenic dural inflammation was important. And we looked at that and we could find no effect on CGRP of this particular compound, which was a Pfizer compound at the time. So we predicted the triptans would work fine and dandy. This predicted this drug would not work in a clinical trial. And it's very important. I mean, can we develop animal models that will stop a lot of wasted resources, and particularly stop patients having to take things that aren't going to be useful? We looked at the substance P question. You can see that you don't have to have a very creative statistical knowledge to understand that didn't do anything at all. This is the laxate substance P, and so we predicted that that didn't work. I'm going to show you some translation of things all in one slide. What happened to the substance P story? There were 5 randomised placebo-controlled trials. The outcome was just about the same as that outcome there. And even the most bullish Glaxo business person kind of looked at the 2 numbers and thought, no, they need to be able to sell that. That's no good. And then the Pfizer people developed this neurogenic inhibitor, and they looked at that and they said, no, that doesn't look like it's going to work either. But the Boehringer people, and it's noticed that quite a bit of time went between this development because all the resources were wasted on the substance P story. Eventually, one company listened and developed a CGRP receptor antagonist called Bibin 4096BS or Segipen. And you know, the difference between here and there, that's different. That's a little promising. And that got into the New England Journal of Medicine, so they sort of changed their tune when the human data became available. We then did the experiment in humans, looking at migraine and showing that CGRP could be blocked by sumatriptan. So the prediction is that CGRP antagonist would work. And here's 4 different randomised placebo-controlled trials. Some of them very large studies. This is a Merck study, this is a Boehringer study, this is done by BMS, and this was done by Boehringer. So done by Europe, led by the Germans, led by the Americans, whether you do it in Europe or you do it in the US, the results are crystal clear that CGRP receptor antagonists acutely in migraine block the effect. That's fantastic. They're called Telcagepant or Segipan. I call them G-pants. With this business, you just make something up like this, and if enough people use it, then it gets to be the name. I think it's really cool the way that sort of thing happens. It's kind of fun. Part of the whole translation process, really. This one died in toxicology, unfortunately. These two are sitting while the business people work out what to do. Okay, so that's the proof of that. Now, the next thing that's coming along, and it's where we're going to kind of swamp the MS people who've had the biologics to themselves. It's a relatively small condition. The prevalence, 1-year prevalence of MS in this country is the same as cluster headache. So that's, it's a biggish problem, but it's nothing compared to migraine. It's like a mouse compared to migraine. So the next thing would be, if you can interrupt CGRP mechanisms for acute attacks, if you blocked it all the time, we have a preventive effect. Because what we really need is preventives. When anyone goes to see a doctor to get a migraine preventive now, if you want a migraine preventive, you might get a beta blocker and they'll explain to you it came from blood pressure and now it's in head. Or you might get an anticonvulsant like topiramate or valproate. And they'll say to you, oh, it came from epilepsy, but it works in you. Or they'll give you an antidepressant and they'll say, well, that came from depression, but actually it works in migraine as well. And blah, 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 blah. And that's all true, but it's very difficult for patients to hear, oh, you've got migraine and now I'm going to give you something for depression, or you've got migraine and now I'm going to give you something for blood pressure. Where does that come from? So what we're looking at here is a way to develop something where you've got migraine and I'm going to give you a migraine treatment. Stop the clocks. That would be very straightforward for everyone to understand. So the things that have been studied, Amgen has a monoclonal antibody to the receptor, the CGRP receptor. Alder, Tejas, and Labs have antibodies to the CGRP peptide. Prior to last week, we knew this one was in phase 1. The Tejas company was purchased by Lilly for tens of millions of dollars on the basis of this press release. To the positive phase 2 data, that's all we knew. And we knew this was going on, and this one is in clinical study. So last week the world changed, and the results of the 403 study, which I was involved in, were presented in the American Academy. Double-blind, randomised, placebo-controlled. Okay. Migraine patients, no medication overuse. This is a genetically engineered, humanised, human alpha CGRP antibody that they make it in big vats of yeast, like they're cooking up beer or something. And it's given, 1 gram is given intravenously, so 28-day baseline, 1 gram intravenously, and then the endpoint was 5 to 8 weeks, but actually they followed people out to 3 months and even to 6 months, all blinded. And placebo was just an infusion of saline. The primary endpoint, migraine days. I'll show you the full analysis set for proper orthodoxy. 26 sites, e-diary. A migraine day was a tape of migraine. Or probable migraine, that's all pretty clear. I can take that in questions. Baseline of 28 days, I told you, but let me just cut to the chase here. So, 81 patients get the infusion of ALD 403 baseline, 82 people get placebo. You see the difference is P equals 0.03 on the primary endpoint. If you block the CGRP mechanism, there's a group of people who have a reduction in their frequency. This is the beginning of, if you've got migraine, we're going to treat you with a migraine drug. And this is a bench-to-bedside story about understanding the disease and treating people with what they have based on good experimental data. No particular side effect problems. Effect seems to start at about a month, and certainly persistent here at the primary endpoint. What's most interesting is this. And probably this group of people. And here's a group of people, 100% responders. These people there's a group of people who got an infusion, and in 3 months, they had no attacks. No one in placebo did that. It's a phase 1 study. But just imagine that we could develop something that would just if 20% of migraineurs stop them for 3 months cold, or a little bit longer, because we don't know, this study's got to run out, it's run out for 6 months, we don't have the data. That would transform the way we think about treating the disorder. And I'm not thinking that CGRP will be the answer to everything, but it's clearly going to be the answer to some point. Because the other thing that was presented was the Lilly study, which had the same outcome. They dosed subcutaneously every 2 weeks. They got the same statistically significant primary endpoint outcome. They saw a 17% difference between active and placebo and 100% responders. There seems to be a group of people, when we could find them, we could personalise their therapy from dreadful headache to no headache, just with a relatively straightforward treatment. Last thing is imaging. The brain is important. Weil showed us that at the start. We've been able to show on PET this pontine area of activation, which is where the locus coeruleus would be. It's quite interesting. We've been able to show with PETs, I mean, probably doesn't sound too exciting in some level, but the pontine activation materialises with the pain. I mean, migraine, hemicrania, migraine, it was originally described as a one-sided headache. So as a neurologist, understanding the structures that cause the one-sidedness are quite interesting to me. And it enables one to explain some of these things to patients. So I'll just show you this one. This is the premonitory study. This is a little bit where we're going at the moment with this. You know, the problem with migraine is we study it when the pain has come. Patients have symptoms maybe hours or a day beforehand, yawning, thirst, they get moody, they crave things. The brain is changing in the period beforehand. Now you can trigger their attacks, unfortunately, you can trigger the premonitory symptoms. So you can get rid of the pain. You can start to look at what's going on in the brain just when they're having this other symptomatology. We really focused on people who yawn because that's dopaminergic. But a whole lot of laboratory work I haven't shown you to point to some areas in the brain that the hypothesis was, old-fashioned word, that there will be hypothalamic activation in this premonitory phase, and lo and behold, there is hypothalamic activation in the premonitory phase. We will follow this up. We will follow this up with the imaging here. This is really important, understanding where, because with PET I can do this once in a group like this. With the sort of techniques that Steve and Fernando have developed, I can do this serially over time. I will get migraineurs to come in, I hope, with the help of the Migraine Trust, patient groups, and come and have repeated imaging in our unit, so we can sort this problem out in a way that others haven't been able to do. We're even starting to understand where things like the photophobia and nausea may be coming from. And again, these are targets for better functional imaging that I'll be able to do in this place. I've tried to show you that if you dissect the mechanisms, you can use experimental animals in a very careful and thoughtful and proper way to dissect mechanisms you can test in humans. But if you never test them in humans, you just never know whether it's worthwhile or not. And the fantastic, attractive thing about CRM, the environment here, is to be able to test these questions. I want to develop more things like the CGRP story, and I certainly don't want to die before the next one gets finished. I want to accelerate these things, and the opportunity to work in this collegiate environment that I found here, I'm sure this is going to enable us to change the scope of migraine. You know, when my timer says I have to stop, so that's perfect. I use this slide to encourage my colleagues in the industry to think big. I mean, you know, migraine's very common. Maybe 15% of the population on the earth, that is to say. And you know, if it occurred in other places, just imagine how huge it would be if you could have something that, because they're a brain, this is taken from the Star Trek medical manual. Now you know, I'm dressed in orange and talking about Star Trek. You're going to know this is, it's almost the psychiatry inaugural lecture. So sort of, better not go there too far. This Institute of Psychiatry. This is the Star Trek medical manual. This is comparative neurobiology of various species throughout the planet, if you want to believe that. And you know, so I think that when the first Andorian with migraine comes along, what we're going to do is we're going to be able to get them in the scan. And I think they'll look something like this when we get them in the MRI scanner. And then we'll really know that we've come to the future. I'm grateful for the opportunity to speak. I'm so very pleased to be here. I'm pleased to be able to do the things that I do. I hope to engage with as many of you as possible, and I thank everyone for your turning up this time and your